This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Well, hi, I'm Maisha Robinson from the Mayo Clinic in Jacksonville, Florida. I'm joined today by my colleague and author of the paper, The Aligned Framework, a parent-informed approach to prognostic communication for infants with neurologic conditions, Monica Lemmon. Monica is a child neurologist at Duke University. So prognostication, many of us know, can be challenging in a number of neurologic diseases due to uncertainty, really about the course of disease, and really because of that desire also to maintain a sense of hope for patients and their family members. Now, I'm an adult neuropalliative care physician and certainly understand the amount of care which has to be provided when having these conversations. However, when discussing prognosis with parents of children with neurologic conditions, even more sensitivity must be applied. And given this, I'm delighted to be able to talk to Monica about her approach to these important discussions. So let's get started. Monica, there are a number of tools and guides that are available for clinicians already to use when discussing prognosis or when they're delivering difficult news. Can you spend some time telling us why we need a specific framework for discussing prognosis with parents of infants with neurologic conditions?
Absolutely. It's true. There are quite a number of outstanding communication skills, tools, and frameworks out there, several of which have arisen from the disciplines of palliative care and oncology. And there is no doubt that many tenets of high quality communication are universal. I do think that there are some key differences in how we deliver information in this particular context as compared to adult settings. For example, in adult settings like the ones that you practice in, many conversations might center the person's life and function prior to a neurologic event or illness, or they might focus on the potential for loss of independence. And in the context of neonatal conditions, parents already expect to take home a baby who's entirely dependent on them. Often our conversations are about what it looks like to extend or change the nature of that dependence. But really, when we set out to do this work, our primary goal was to center parent voices, to ask them their preferences for how to hear prognostic information. A number of the themes and recommendations you'll see in the paper that arose echo principles that have been put forward in other tools. And I think it's encouraging that the participants in our study endorse some of these longstanding ideas.
As you spend some time looking at how to have these conversations well, you may have come across some common pitfalls that clinicians may run into when discussing prognosis with parents. Can you tell us how the aligned framework might help?
I'll say that not only have I come across a lot of pitfalls, I myself fall victim to a number of pitfalls. And I would say first, really a common pitfall we see is lack of preparation. And our findings highlight the importance of preparing thoughtfully for serious conversations, considering the right venue, who the family wants present, ensuring that our teams are on the same page. And the good news is that the participants in our study gave useful suggestions on how to do this better and how we might think about preparing for serious conversations in advance. The second is avoiding hard news, not saying the tough thing. And participants in our study directly talked about how sugarcoating or avoiding difficult news could undermine their trust in the team. And in some ways, I find this finding helpful in reassuring clinicians that it's okay to share serious news and to do so transparently. I could keep going, but I'll end on information overload. I think our findings highlighted that parents appreciated when clinicians avoided jargon and they paced information delivery. In my own experience, this requires some intention and some effort. I think many of us are very good at going on a long spiel. That's something that I do a lot when I'm nervous. I start to talk about things that are more comfortable to me. And that could be detailed medical information, that EEG finding or that MRI finding. A useful strategy to combat this is to first recognize it and to think about ways to mitigate it, and also to create space within your spiel to check understanding and to make room for questions.
You mentioned that parents want clinicians to be transparent when having conversations about prognosis. And one of the things that I found very interesting about the paper is really the importance of that informed step that you all mentioned in the framework. And so focusing really on being as honest as possible when discussing prognosis, but also providing information that's balanced. Will you talk some about how to provide balanced information, particularly when the prognosis is not expected to be good?
I think at first glance, the two findings you're referencing, the one to be transparent and also to provide balanced information, they might seem at odds with one another. But as we've thought about this more carefully, they can easily occur alongside each other and they're quite aligned. So, participants described two primary ways in which they hoped for balanced information delivery. First, they appreciated when clinicians talked about function in addition to impairment. For example, imagine that you're talking with a family of a child who's not expected to be able to speak. One might traditionally use language like, your child will never talk. One way of describing that outcome in a way that centers function might be, your child will communicate her needs through sounds or movements that you come to recognize, and not through words like we're speaking now. The second way of delivering information doesn't provide falsely positive news. It simply describes the outcome in a way that centers what the child could be able to do, as opposed to only speaking to impairment. Another way to think about this is to include speaking about development and function more broadly and not isolating one's counseling to the domains that we think are going to have impairment. And so in my own practice, I'll often introduce this type of talk with something like, sometimes we spend a lot of time talking about what kids might not be able to do. I'd also like to take a moment to share what I expect your daughter will be able to do. Children with this type of brain injury laugh, smile, they recognize their parents' faces. The goal of language like this is to paint a more full and honest picture of what life might look like. The second way that families described the need for balanced information delivery was not to repeat grim news unnecessarily. And importantly, this didn't mean never sharing grim news. It simply emphasized that once it was clear that families had heard, processed, and understood a certain outcome, repeating that information without a reason to do so could be painful. Just to speak a bit more to this, there's no doubt that there are some cases in which this particular principle might be less relevant, and this framework isn't meant to be prescriptive. Instead, it's meant to serve as a guide that you can use as the situation requires.
I love the way you phrase some of that. This is what we think your child might be able to do, and this is what we expect them to be able to do, versus just focusing on some of the unfortunate aspects of the condition. That's wonderful and a good point that I can take with me. Monica, what did you find most surprising about what the parents shared regarding their experiences with clinicians discussing prognosis for their children, and why?
I found a lot of things surprising in this data set. I think one of them is, in some ways, the lack of variability in the findings. There's no doubt that each of these families had, very unique, important perspective and heterogeneous experiences. And despite that, we were able to hear salient, repeated ideas throughout the data. I think that helped me feel confident that the themes we present here are things that we can add to our toolkit as we think about counseling families at large. The other piece is a lot of what we just talked about. Some of the ideas about balanced information delivery were really humbling. And frankly, my counseling has changed as a result of that finding. And as it has, I've realized that describing outcome in that way has actually been really hard. It's required me to shift my thinking. It's required me to read more, not only about a given outcome, but really concretely about how that outcome impacts function and how that might show up in daily life.
May I run a case by you and ask you to walk us through how you would use the aligned framework to discuss prognosis with the parents of this newborn?
Absolutely.
So a baby is born at 28 weeks via emergency cesarean section after preterm rupture of membranes leading to fetal distress. APGAR scores were 3 at 1 minute and 4 at 5 minutes. She was taken to the neonatal ICU where her evaluation revealed a grade 3 intraventricular hemorrhage. The result of the ultrasound was shared with her parents, but they understandably had many questions about what this will mean for their little girl. How would you approach this?
There's probably variability in how listeners might estimate prognosis in this scenario. And one might ask a bunch of questions about the imaging findings or other prenatal or neonatal factors. And I think what's most helpful here is rather than to focus on estimating prognosis, let's just think about how we might communicate it. And let's assume that this is a child with a risk of hemiplegic cerebral palsy and potentially some other neurodevelopmental impairments, but that, some children with this type of injury may go on to have typical neurodevelopment. So I would start by thinking about my approach. Learning who the family might want in that conversation. Is there a bedside nurse who knows the family well? Can there be a social worker present? Ask the family who they want there. And, I'd check in with my neonatology colleagues and colleagues on other teams to make sure we're on the same page, not only about the plan, but about how we see both the short and long-term outcome. Once we've started the conversation, I would lead prognostic discussion with questions or prompts. So things like, tell me what you've heard about your daughter's brain. I might ask permission prior to proceeding, and that might look like asking a question like, when something like this happens, many parents want to know more about what this means for their child's future development. Would you like to talk about that today? After that, I might ask a bit about information preferences or about what aspects of development are most important to them, and then I would hopefully tailor my content accordingly. When I get into the prognostic counseling, I often start with a narrative, telling the story of what the next steps in the hospital might look like, when we might repeat imaging, how we'll monitor for post-hemorrhagic hydrocephalus. Hopefully along the way, I'm interrupting my spiel to check in, to check for understanding, to allow space for questions. And then I begin to tell the story of what life might look like at home, thinking about early intervention, medical appointments, things like that. And when I get to talking about outcomes, I often separate these by domain because I find that lumping them together often does a disservice to our ability to describe the impact on daily life. And so in this particular case, let's say I was focusing on motor outcome. I might say something like, when we think about motor outcomes or movements, there's a big range in what's possible. On one end of the range, children have typical development and walk and run and use their arms like most kids do. On the other end of that range, children have weakness and stiffness on their right side. For these children, they might need a device like a brace that they wear to support their muscles. They may not be able to use their right hand and instead might need to use their left hand to feed themselves or to write. What's most likely is something in between, in which your daughter has some weakness on her right side that you and others notice when she walks or uses her hands, but she can do those things without extra support or extra equipment. After all of that, I would hopefully stop and say, that's a lot of information. What questions do you have? Also, along the way, I'd hope that I would communicate with empathy, that I would lean on my colleagues with expertise in providing emotional support to step in when I needed help. And I would come ready with peer support organizations that might be relevant to a given family. In some settings, I might even look at resources with parents in real time to help them identify information that's helpful and information that's accurate.
Thank you so much for that answer. That best case, worst case, most likely case scenario is a great tool to use really when communicating prognosis. So I've learned a lot from just talking with you, Monica, but if you had to offer 2 or 3 pearls for neurology clinicians about how to approach prognostication discussions with parents of children with neurologic conditions, what would they be?
I think really it boils down to a few key ideas. Treat serious illness communication with reverence. These conversations are high stakes, and that means preparing for them, defining and practicing the headline statement or the key idea that you want to communicate. Understand and minimize biases you might bring to the table. Invest time and resources into continuous improvement. Seek education where you can find it. When I think about actually holding the conversation, I really think we should lead with listening. Understand what the family already knows, elicit their goals, understand how they like to hear information and what outcomes are most important to them. And I think finally, give yourself some grace. This is really hard to do. And we all might say things in ways that we wish we hadn't. And if that happens, it's okay to own it and to say, I'm sorry. I wish I would have said that differently. Can I try again? And the key is not to do a perfect job every time. The key is to use each experience as a way to grow and a way to improve and to do our best.
Well, thank you. And thank you all for listening to this episode of the Neurology Podcast. Monica, it's just been an absolute pleasure talking with you about your paper, The Aligned Framework, a Parent-Informed Approach to Prognostic Communication for Infants with Neurologic Conditions. It's published in the journal Neurology, so please check it out.
Thank you so much. It's been a joy to be here.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about. The views and opinions of the participants in this podcast do not necessarily reflect those of the journal Neurology or the AAN. Disclosures of the participants are included in the show descriptions, reached by a link on the neurology.org website.